hours, where cocaine has a half-life of about 1 hour. Since nobody here actually deals with with cocaine, I mean, this is the high-class drug, and so I'm sure your people don't ever use cocaine, but you can read about it, okay? But what I do know here, now, I know what's going to happen in this next slide, and you're going to hate me, but I know the next one is the fourth chili, okay? So, I'm going to do these, and then we'll get through marijuana, and then I'll give you a papal blessing, and then those of you that have to leave can leave, and then we can talk about anybody that has questions, and then I'll be more than happy to try to answer them if I can. So, Frank said the following. Now he's observing the barb lady that's helping, and he's noticing that this lady is really getting more beautiful by the minute, and is the only one that's helping him. But he thinks he's eating nuclear waste. Okay, I'm eating as a Chilean aphrodisiac. Okay, so let's go to cannabis. Okay. Cannabis is second only to alcohol. I need to say just a couple of things. First and foremost, because I'm sure 3/4 of you at some point in time may have tried cannabis, and maybe some of you are using it now. I don't make judgments, and that's not my part. But what I would absolutely positively tell you is if you use cannabis, you should never drive a motor vehicle. I tell the story is I'm out with two of my lawyer friends. We come out of a restaurant. One's been drinking, has 4 brewskis, one smokes a joint. I will get in the car with the alcohol guy. And the reason is because I had a most terrible case in which a 21-year-old took her 2 sisters, 18 and 17, to celebrate her 21st birthday. They went to an Italian restaurant. They went in, they all had beer, that was okay. They came out, the 21-year-old smoked a joint, gets in her car, drives about 1.2 miles, rear ends a car with 3 kids under the age of 5 in the back seat and kills all 3. Now, why did that happen? Because the main problem in using marijuana, in my judgment, and driving is a lack of depth perception. I have a lot of cases where people rear end someone. I have a lot of cases where they take a right-hand turn and sideswipe 2 cars. Okay? I mean, nobody's ever going to die of marijuana, that's for sure. I mean, all the carcinogenicity may be an entirely separate issue. But the point is, it's to think that we're on the verge of legalizing this when we know so much about marijuana now and we know more and more about alcohol now, I just find it incomprehensible that we would do that. But Washington and Colorado do, and they get the revenue, and then they put the cars right outside the pot shop. The guy comes out, smokes a joint, gets in the drive. He goes less than a block. The police arrest him. Then they get the revenue from them. Okay, so what am I trying to say? We don't know anything about the purity of marijuana by and large. It can range somewhere up to about 12%. Most of it is 1.25% to maybe 2.5%. We don't know how it's basically smoked. How many hits you take off of it, how long you hold it in your lungs. So 2 people can be smoking the exact same quality joint and have dramatically different levels. Okay? Usually with smoking it, it's usually somewhere between 5 and 20 milligrams. Marinol is a capsule that you can buy. It's a known quantity. And you can take it orally in foodstuffs and brownies and all that other sort of stuff. But primarily it's by smoking. Okay. Eaten or by smoking? Okay, what you need to know, just some simple pharmacology. It's fat soluble, which means it moves in and out of fat cells, which means that what happens is, by the time you take your first hit, within about 20 to 22 seconds, you can actually see a demonstrable level of THC circulating in blood. THC is the psychoactive component in marijuana. It's a cannabinoid. There are many cannabinoids in marijuana, but it's the only psychoactive one. Okay, and that's where they get this so-called pleasurable effect out of the marijuana. As I say, between 8 to 9 seconds, you can feel it. It peaks usually. What's interesting about marijuana and THC, it rises very fast. It reaches its peak somewhere between 10 to 20 minutes. The peak may last for as high as about 30 minutes, and then it rapidly falls. Okay? So usually the rondo from start to finish, in my opinion, is around 3.5 to 4.5 hours. At the end of that 3.5 to 4.5 hours, the level of THC in the blood is usually 2 nanograms or less. Okay? So it's important to know when the person used it, how much they used, or whatever, in order to try to determine where they were on their pharmacokinetic curve. Okay? There are 4 basic sort of responses. The most common one that I see is this euphoria, sense of well-being, relaxation, calming. That's what recreation has done. It's used for the treatment of nausea of chemotherapy in cancer patients. And it's also being studied for about 8 or 10 different other things that probably have merit in the long term. But this is the reason why individuals basically use it. It can also relax people in the process of relaxing it. It acts as a sedative. It can also act as a pain reliever. Some people take it. I would only tell you that to get a medical marijuana card from your person, that and $5 will buy you Starbucks coffee. Because all a doctor is saying is, I see no reason why you can't use the drug, smoke the drug. I mean, it has no, somebody says, well, I've been using it since 5 years and I have a medical marijuana card. Well, it really doesn't have any. I mean, there are people who legitimately have a problem and they get the benefit of it. A lot of people smoke a joint to go to bed and they wake one up when they get up in the morning. But the horror stories that happen, I just I can't tell you how bad some of them are. Okay, and it also can cause some sort of hallucinogenic. Not frequently, but you can get some people who are paranoid and slightly delusional over chronic marijuana. And I would also point out, you probably hear that you can detect marijuana in people multiple days after they stop using. And there have been some studies where they incarcerate people, or or they've been injured, and they put them in a study and they check them out, and it's coming down, it actually is negative. 2 days later it's up to 2 nanograms and whatever. And that's because it moves in and out of fat cells, okay? But it's a very small amount. But it is true. And in a urine sample, which I'll go through in just a minute, you can sometime in a chronic person find positive THC levels 3 weeks later, where you wouldn't find it in a blood sample. Here's the important thing that you need to know about marijuana. The psychoactive component is THC. The liver recognizes it as foreign, so the first thing it does, when it goes through the liver, it puts a hydroxyl group on it. 11-hydroxy-THC is also psychoactive. And what's really important about it is it's very short-acting. If you get a result back that has 11-hydroxy-THC, in my judgment, it means the individual used within about 2 hours. Okay? The THCA, or sometimes called carboxy-THC, is the major inactive metabolite. I like to say you can have a pound of it in your blood and it wouldn't do anything. It doesn't act on the cannabinoid receptors in the brain. It just, if you get a positive THCA or carboxy-THC, it means your individual has used marijuana, because you don't get it from eating Krispy Kreme donuts. So that's one of the things you need to know. And again, I saw one study where they say they found it up to 45 days after last use. I think maybe 3 weeks is probably the outside in my experience, but it's in a urine sample. Again, you'll also see it done screening-wise. In a urine sample, it's primarily an immunoassay, AMIT. In a blood sample, it's ELISA. There are ways that some laboratories will do color tests on or microscopic examination, but the key here for you is it needs to be confirmed by GC mass spec. Because again, a lot of what I see is your client may go to somebody, they do a point of care testing right on the spot, it's indicated positive, and it's never done anything more with. And that can be very wrong in terms of what it really means as it relates to your client based on a single point of care device. Okay? Alrighty, so there are other ones. I can go over some other things, and there's absolutely orgasmic stuff related to opiates and PCP and inhalants that you can read tonight while you're on the potty. But I do want to add, does anybody have any questions? Yes,
Yes,
ma'am.
I have a question about diluted tests. Can you talk a little bit about diluted tests and why a test would be diluted? Because oftentimes the department uses a diluted test to say that this proves something, that this shows that someone was drinking tons of water to try to dilute, therefore they're trying to cover something up.
Well, no, I mean, there are people that have shy bladder, okay, which means they're asked to void and they can't. So what they try to do is they hydrate the person in order to get fluids in to take it. The real problem comes in where essentially the laboratory gets a liquid in which there's virtually no creatinine present, which means that that person essentially could have substituted water, or I was involved in these artificial means, you know. I got national television because I had 5 different artificial penises on a rack like this, showing them how these people could wear this. The person looking could see what they thought was their organ, and they could see the urine going in it, which was on a little pouch to the side. It was heated up by a little thing that gave it physiological, okay, and then they would submit that. They also had vaginas that was the same way as well. So the point is that they're trying to make sure that it's a valid sample. Now, a laboratory will sometimes give you a dilute sample and just say it's dilute. If it's basically has little or no creatinine, or so specific gravity is bad, they will basically reject the sample as being not physiological. But a law enforcement person could try to make that argument, because again, a lot of people go trying to get a negative results. I mean, I had one person that came in every day for 5 weeks trying to get their amphetamine level below detection because they were applying for a postal position. So they needed to work it out, and they were drinking all this water. So I would say I would not use that as an absolute. Sometimes it is the case, but there are many cases where individuals have a difficulty voiding. Yes, sir.
Can you talk a little bit about levels in the blood, marijuana levels specifically? You were talking about people who are chronic users maybe being in the system up to 3 weeks or even 45 days. Here they like, the judges and the department like to say we want to see the levels going down. In fact, can the levels not vary even if you have not been using, say from 9 days, post-use, 10 days, 12 days? Could the levels not vary even if you hadn't used the substance again?
Well, they tend to do it, especially, you mean in the urine sample, that's what
Correct.
you're dealing with,
Yes,
right?
exactly.
Well, again, it goes back to the fat solubility, because it moves in and out of fat cells. So what happens is the elimination is a series of small peaks, small rises and falls and whatever. So if you were measured on 2 straight days, I mean, you could have a level where you're X the first day and X plus 10 the second day. But it wouldn't mean that you used again. Okay? In general, when you cessate and stop, the levels tend to empirically fall over time. And then sometimes if you get I deal a lot with the Attorney General's office when I'm dealing, I testify for the Respiratory Care Board, and they have respiratory therapists that will sometimes have this kind of bouncing kind of a thing, whether they actually fell off the wagon or not. And in some cases, I don't think I can say with scientific certainty they did, but other cases you can clearly see that they used again based on the amount of the THC and or the carboxy-THC. But because there's no standard dosage within a particular use, I would say empirically you would see the level go down, but I would argue that there can be what's called not only individual variability within the person, but the analytical variability within the test. Because if you go back to the lab who did it, they will say, well, this result is X plus or minus 10%. So I mean, you could ultimately be getting the same thought by a judge, which would be incorrect.
And doesn't it also depend on what time of day? Maybe if you provide your test with the first void of the day, would your levels not tend to be higher than if you did it later in the day?
Well, no, that's a mixed bag, because if you're giving your sample at the first void, then chances are your bladder is pretty full. which means you already have a lot of liquid in there, as opposed to you give a sample then, but then you go in 4 hours later, you give another sample, then you're only dealing with the urine that's formed from the time the last void to this point in time. And the other thing, I wanted to talk a little bit about was, this idea of passive inhalation. Everybody wants to know, because the person will say, well, I didn't smoke it, but I was around all my friends and they were smoking. And there are studies that demonstrate you can experience passive inhalation. Now, most of the studies put somebody in a 4x6 room and for 4 hours pumping marijuana smoke in there, okay? And yeah, they'll get a demonstrable level in their urine that would indicate it's positive. But if you look at that in relationship to sometimes the levels that you get in the quantitation, you would think that's not really very consistent with the likelihood that it's been this passive inhalation. But it can occur. I mean, I would not throw it away, but it can occur. Okay?
Significantly over that minimum level of testing?
Well, it would occur, it would be above the cutoff in order to even go to the next level of being confirmed. If it didn't meet the first criteria cutoff, it would have been reported as negative. But it can occur, but I would not use that as my typical explanation, because that, again, that's under a very restricted kind of concern, a large amount of smoke coming in a relatively long period of time. Usually that's not what people get when they hang around in a room. They go in and out of the room and they come through and somebody's smoking a joint or whatever. But I would not want to say that it could not happen. Okay? Yeah.
So as you were talking about the levels of THC to rise a bit as it's being eliminated, what would be the higher threshold of the amount that it can increase while being eliminated? 10, 20, 30 mgs?
Well,
we say bullshit.
Well, again, you're talking about essentially two components in the answer that you get. One is the actual variability that occurs between the physiological excretion, and secondarily, if you took that same urine test and ran it twice, you're not going to get exactly the same level each time. It should not be worlds apart, but it's going to be, plus or minus 10 or 15%. And in the urine sample, the best thing that you can almost say is that it's use. Now, if the person are already known to be used and they're supposed to abstain, then I would say that's a case that might be worthy of. There's an algorithm that Marilyn Eustace put together that can give you some idea on when the person last used based on a ratio of the THC to the THCA. Now, in some cases, that doesn't apply to you because you only maybe have only the urine sample. But there are some studies that are going on that try to get some idea of what the range of time was when the person last used. It's, I mean, a lot of studies are going on. Probably within the next year and a half or so, they're going to come out with a proposed per se law. In Arizona and Washington, it's 5 nanograms. Most people would argue that's not really a valid result. And in California, I or no one else can go in and make a representation about any other kind of results, per se laws or whatever. But there's going to come a time that's probably going to be happening. But so to answer really your question, I think scientifically the judge can understand that there is a movement of the drug in and out of fat cells, which causes it to be a slightly higher or lower depending upon when you take that sample.
So what is slightly higher? The cutoff levels for pack tox are 50 mgs. And so what is a higher or low cutoff? Because we usually tests somebody's been smoking is a couple hundred, 300, 400, can go up into the thousands. So
well, you can if you're a chronic user. I mean, if you get it right in line. I mean, most of the time, I mean, a chronic user to me has usually triple digit. Now, when he or she cessates, then in theory, that ought to go down. Now, it may take longer, but in the absence of any further use, it's not like there were 300 and then it went up to 1,100.
Right.
That isn't going to happen.
But if it's 150, it's going, the next test is 105, and then it goes up to 130 again. that could be within the
Yeah.
normal.
I would say that could be within the normal variability of the individual coupled with the component of the analytical variability.
Even if the follow-up test was 5, 6, 7 days later?
Say again?
Even if the follow-up test was 5, 6, or 7 days later?
Well, yeah, in that case, it would depend upon a little bit about understanding the history of the drug use of the individual. I mean, everybody's got to start the first time, but you're not going to see that kind of dramatic changes in an individual who used on a Friday and gets into this problem in and of itself because they used it once. I mean, as you know, most people who use it, if they get the pleasurable effects, they want to continue, which is where the dependence comes in. And what I call chronic use is a person that uses at least once to twice a day. And again, the quality of the marijuana they get and how much they put in a bong or how much they put in a joint, all of that has some bearing on what the level would be.
And the recognition here by some judges is that people are using it for legitimate medical purposes. And so we'll get an order that says marijuana levels to stay within medically accepted levels. And do you have any comment on medically accepted?
To-
Are there medically accepted levels?
Well, no, if medical accepted levels are they talking about, then the first thing you have to do is go to a blood or plasma level. You can't go to a urine level. A urine level, as I said, only indicates use. There are studies that indicate certain levels are helpful in treating certain kinds of conditions. Again, remember, nobody dies of marijuana overdose per se. So when you say acceptable level, if the prescribing, what I would do in a case like that is I'd take one step back and go to the clinician who's doing that and saying, is your recommendation that my client either take this Marinol, which is a known concentration twice a day or whatever, or are you telling them you want them to smoke a joint in the morning and one before bedtime? Because, and what the physician is going to do is get the feedback from the person saying, yeah, this is helping me fall asleep, it's helping me do so-and-so, but it isn't going to be based on a specific level. I think the judges in those situations are trying to translate prescription drug medication in therapeutic levels with what you might do in marijuana, and that doesn't happen. Yes, ma'am.
I just have a couple of questions. So you mentioned about marijuana dependence. Are you talking about that the person can be addicted to marijuana, or are you just talking about chasing the high?
Yeah, no, well, there's some people are thought to be psychologically prone to addiction potential. I don't think it's established in everyone, but I think there are people, there are scientific papers that would suggest that marijuana can have a dependency component, which means the person moves in the direction of frequent use. I don't believe that you have the same kind of withdrawal that you would have for opiate or stimulants or whatever, but I think individuals can develop dependency.
And then in terms of the testing, don't different agencies set different levels? Like I had read something like the military when they're testing, that they accept a different number than another agency.
Well, it does. I mean, for example, a lot of the laboratories, and I guess I should tell you, I was president and CEO of Pacific Toxicology for 14 years, okay? I left in 2004. What they did on 2004 and one day after it, I have nothing to do with, okay? And I'm not, I mean, I know the people there, I'm not making any points, but the only thing I can do is insert the suppository when I want something done. Because I hired some of those people, so I do know. But the point is, I'm not related to them. But your point's a good one, because the laboratory ultimately puts together testing with different criteria and different levels. And for example, in the urine drug test, it may be what's called a SAMHSA-related test, where the levels have put the basic cutoff levels have been promulgated by the federal government, okay? But you could go in, which I had a client do one time. He wanted everything tested to the lowest level except marijuana. He didn't want that to be tested at all because he used marijuana every day. Okay, so, but I mean, you can do that. So to answer your question, there are different laboratories that can have the same kind of testing, but using different cutoff levels. So it's important for you to understand what they're using. And I think Jeff Meyer is the technical director in the drug lab, and he would be more than happy to tell you what other options there may be. But in general, it's known to be that cutoff. And it's important because it's so if you said a cutoff was 200, for example, if you really got the initial screening test and it was 199, that's negative. You know, so I mean, you have to understand, you know, now if that was President Obama's urine, you know, you would want to make sure you knew exactly, you know, what it was and if it was there or if it wasn't there, kind of a thing. So my point is that in and of itself, a negative doesn't always mean exactly what it means. And I would say, to the degree that sometimes this may be in the back of your mind, it could be helpful, you may need to explore that. Because they can take that same sample and test it at a much lower level, if that was to be desirable.
Because what I'm thinking is, or what I thought after I was reading this is, if at 200 you get your kids taken away, but at 100, you know, you can still fight in the military. You know what I mean? I mean, it just...
Yeah, no, I mean, those are excellent points. I think, again, to me, going as it relates to the wonderful work that you guys do, guys and gals do, honestly, you do, and I applaud it. And marijuana, what it is, and knowing it's acceptable, but to realize that a parent could get in a car with a child, I'm telling you, that is scary. And because you get this false sense of well-being. I mean, you just think you know, and most of us don't realize how complex operating a motor vehicle is. But I see the end result of these all the time, and they're heartbreaking because it's always the worst kind of scenario.
What if it's someone who's been using for 30 years? They've been smoking a joint every night for 30 years, so their test, you know, it doesn't affect, well, I don't know, that's the question. Does it affect them the same way if they have higher levels but they've been using it for years?
Well, the tolerance component, I mean, the drug is still acting on the alpha and beta cannabinoid receptors in the brain. It's not that that's going away. It's just that it usually takes more of it to do that. But if you're saying to me, if a guy, I mean, I have a case right now where the guy is 34 years old and has been using marijuana twice a day for 14 years. No, 24. 10 years. He's been using since he was 14 years old. Okay? And he got stopped at a checkpoint. But his FSTs were so screwed up, meaning the divided attention, the walk and turn, that he couldn't do them, but he had no bad driving. So to answer your question, I mean, if you're saying as a parent, could that parent be smoking for 10 years or whatever and be all right as compared to somebody else in a family that's using marijuana? I don't think the science would say it's all right.
Well, wasn't there a statement made earlier that, you know, we can have attorneys or clinicians or whatever testing 0.1 in the morning, 0.15 in the day, and we wouldn't know. So if somebody can function better than others on alcohol, that doesn't translate to marijuana?
Oh, it can. I mean, there is individual variability. I mean, the guy who said that at this presentation is a genius. In fact, forgetfulness is a sign of genius, but I just forgot who said that, okay? So yeah, but no, you're exactly, it's true, and in a certain context you might be able to argue that. I mean, from a defensive posture you might be able to argue that. There is individual variability. But in his problem, the guy I was referring to, he couldn't do any of the divided attention tasks. I mean, he almost fell over when he did the one-leg stand, and the walk and turn, he missed every step up, didn't turn around, all that kind of stuff. Now, if you don't have an alternative explanation for that, like he's got an ankle injury or a knee injury or a hip injury and he can't do it, then everybody's gonna look to believing it's the drug. I,
So we're kind of in the business of disproving, right? Like to
Yeah.
prove that that doesn't necessarily mean someone can't parent. How do
That they're
we?
impaired from adequately
Right, that they're
parenting.
impaired from parenting. So if that person is having that at night when they're not driving and their kids are in the bed, what's the science that says that they're unable to parent or they're impaired from being able to parent over time?
no, well, I would say the skill as well as parenting, using the two examples that